In this work, we address the critical public health problem tuberculosis, which is especially prevalent in India. Namely, there were 2.7 million cases in 2017. The treatment regimen for TB is a minimum of 6 months of daily antibiotics, which have their own side effects in addition to the symptoms of TB. Accordingly, a major challenge in TB treatment is low adherence, which can lead to many negative health outcomes. One way this is being addressed is with 99 dots, which provides patients with an outer sleeve for their medications, such that when they remove a pill, it reveals a phone number that they can call to prove they took their medication. These calls populate a dashboard that their health workers would see like this. Here, a row is one patient, and a column is 1 day of adherence information. In practice, health workers use this information to help decide which patients to visit or call. But this reactive approach relies on patients missing many doses in a row. So our goal is to build models that detect risk earlier to enable health workers to plan interventions proactively to ultimately improve adherence. We analyzed data from 17,000 patients in Mumbai, which includes over 2 million dosage records as well as demographics about each patient. The major challenge we face is that we work with a massive observational dataset in which workers don't regularly record interventions. So what happens when we fit a model to this data? Consider this case of a patient whose future adherence we are trying to predict. One would guess that they will continue to miss doses, but in the actual data, we see that they change their behavior. This is likely due to an unseen intervention carried out on the 11th day. But since we can't see that intervention, if we trained a model on this sample, all it would learn is that bad behavior leads to good behavior. So the next time the model sees someone with bad behavior, it will assume they will follow with good behavior, recommending no intervention to a patient that actually needs it most. In this work, we present a general framework to address this unseen intervention problem, using a dual screening procedure and prediction task that naturally remove intervention effects from the data. We then demonstrate that our framework generates models capable of making valid recommendations to health workers despite this messy observational dataset. The model we developed, named LEAP, is seen here and has two main parts: an LSTM that processes the raw adherence sequence of each patient, and a dense layer that processes some engineered features that capture patient calling behavior as well as demographics. Preliminary results show that our model could catch almost 2 times as many missed doses as current heuristic baselines used by the system. We also introduce an application of decision-focused learning, which incorporates an optimization problem into the training loop of the model. Here, the optimization task is for health workers to choose a limited set of patients to visit daily, with the goal of intervening before the most missed doses. We show that by tuning our LEAP model with decision-focused learning, we can achieve even further improved decision quality. We are excited about our continued work with the City TB Office of Mumbai to pilot our model on the 99 Dots platform. For more information and results from our paper, please see our preprint here.